All right, now we're going to talk about antiviral medications. So characteristics of viruses, they cannot replicate independently. They need to attach to a host cell and utilize that host cell's proteins, DNA, RNA in order to replicate. Characteristics of antiviral medications. Well, they need to be able to enter cells infected with the virus, interfere with the viral synthesis and regulation, interfere with the ability of the virus to bind to cells, and sometimes we just want them to stimulate the body's immune system. Here's some viruses that respond to antiviral therapy. Influenza A, B, RSV, herpes virus, cytomegalovirus, HIV, and hepatitis B and C. So let's talk about some respiratory viral medications. Oseltamivir is probably the one you've heard of the most, also named Tamiflu. There's also Rimanidine. That's not on here, but that's another common one that you'll see, especially used in children over 7. The exact action we're not 100% sure of exactly, but we believe that it prevents the shedding of the viral protein. And again, we use these for influenza A and B and RSV. Oseltamivir is the only antiviral agent that we know to be effective against H1N1 and avian flu. So you'll see that a lot, especially in Asian countries. They utilize a lot of oseltamivir. Adverse reactions. The most common adverse reaction, of course, is GI distress, but some people complain of a little bit of dizziness, and some people may complain of insomnia as well. Be careful in people with renal or hepatic impairment. And then, of course, it's going to interact with a live flu vaccine, which just makes sense. Patient teaching. This is the big thing with oseltamivir or any of these respiratory viral agents. We need to begin treatment within 48 hours or about 2 days of onset of symptoms. It's not a substitute for the flu vaccine. It's still recommended they get a flu vaccine every year. You don't just say, hey, if I get the flu, I'm going to take Tamiflu. It doesn't really work that way. And of course, just like antibiotics, they need to take the full course. You will still see providers sometimes begin treatment even after 2 days of or 48 hours of the onset of symptoms, just to see if they can help with limiting the course of the virus. This doesn't necessarily eliminate the virus. It just helps limit the course of it, like shorten the course and diminish the symptoms. The problem is, of course, we start showing symptoms early. The early symptoms that we show, a lot of times we just think of them as a cold. We're not too worried about it. It's when we get into full-blown like flu, like, oh my God, I gotta go see somebody. It's already been, 5-7 days. And it's just too late at that point. Again, depending on the severity of it, the doc may still go ahead and try these to see if they can, get some benefit from them. I have absolutely seen that. But where I've seen them be most effective is when mom comes in, she gets, diagnosed with the flu. She's had it for like 5 to 7 days, but then maybe dad or one of the kids starts showing symptoms early on. The doc gives them the medicine for that, and it significantly shortens the symptoms and the course of the virus. So again, they need to try to start it within 48 hours or 2 days of onset of symptoms to be most effective. Herpes and cytomegalovirus agents. Acyclovir is very common. Valcyclovir as well. Those are Zovirix and Valtrex. You've probably heard of those. They inhibit viral DNA replication, and we use these again to treat herpes, varicella, zoster, and prevention of cytomegalovirus. Cytomegalovirus is actually a very common virus. It usually people have no to little signs, like, and it not really much concern for people. However, if someone is immunocompromised, it can become a big problem. And then, of course, in pregnancy, it can greatly affect the newborn. So that's when we're most concerned. But in all honesty, probably most people listening to this has had some sort of cytomegalovirus in the past, and they probably never even knew it. But we're mostly concerned about those immunocompromised people, and then pregnant women. Adverse reactions: GI distress, headache, nephrotoxicity. Be careful in people with renal or hepatic impairment. Be careful with dehydration. We really need to make sure we're encouraging fluids. It's going to interact with other nephrotoxic drugs. Patient teaching. Again, take all prescribed doses exactly as stated by the physician. Again, this isn't a cure. It's just going to improve symptoms. And wear rubber gloves when we apply it topically. You will see some of these, especially for lesions of the mouth. We have topical solutions for those, or topical ointments. The patient would probably do best to go ahead and wear gloves, and you certainly as a nurse would definitely do better wearing gloves when you're applying the topical. Okay, so HIV infection, we've, in school we learn about this a lot. You guys probably know most of this stuff through just high school, let alone if you've taken advanced physiology or microbiology, you probably learned even more about it. It's an RNA retrovirus. It replicates, of course, it's a virus, so it replicates inside human cells. Destroys the CD4 cells, so it's the CD4 levels that we check to see the significance of the infection. Causes immunosufficiency. Symptoms of HIV infection, well, they're really very similar to the flu in a lot of ways. Fever, fatigue, pharyngitis, malaise, which I guess kind of goes along with fatigue, headache, night sweats. Those are some of those symptoms of HIV infection. HIV transmission, we've been hit over the head pretty hard about how HIV is transmitted. Most people probably know that. It's sexual contact, direct blood contact, and mother to child, not spread by casual contact. So contact with blood, semen, vaginal fluids, breast milk, those are the fluids that transmit HIV most prominently. Indication for retroviral or antiretroviral therapy: basically anybody that's affected with HIV or that is in intimate contact with anyone with HIV. So couples who one person has HIV, the other doesn't, they can take, the one with HIV certainly needs to take antiretroviral therapy, but also the person who is not infected, there are some antiretroviral therapies out there to keep them from becoming affected. And then, of course, HIV pregnant, pregnant women with HIV to try to reduce the likelihood of transmitting that to the child. The treatment goal, again, reduce HIV-associated morbidity and mortality, and we've done a great job with this. If any of you guys are old enough to remember back in the 80s when this was the big scare, and even early 90s, it seemed like it was a definite death sentence, a horrible death. And with therapies, with medications, we've been able to extend people's lives, fairly normal lives. Of course, they need to take a regimen of medications. They've got to take it exactly as prescribed. They've got to stay on top of it. It's still arduous as far as the treatment, but it's much, it's not new, thankfully. Thankfully that we've been able to help people a lot with that. The ultimate goal of treatment, I should say here, is to decrease the viral load, right? That's the big thing. We want to make sure we get that viral load down enough to where the people can live as healthy and productive lives as possible. The big thing with antiretroviral therapy, though, is adherence. They have to adhere to the medication regimen. Um, some problems with that is sometimes the frequency can be it can be a bit much. Nowadays, they've got it down to 1 or 2 pills a day, whereas before it was definitely not like that. But it just depends on what's working for that person. It could certainly become more problematic for some people. So the dosage regimen, the pill burden, the adverse effects of these meds, they make people sometimes feel nauseous. Sometimes it causes some anorexia, so they're not wanting to eat, maybe a little weakness. Everyone's going to react differently to them. I've known plenty of people that are on them and do just fine. They say they don't really have many side effects and they're doing great. And then I've seen others who they've also had some other comorbidities with it, but they didn't respond as well. They suffered more of the anorexia and the nausea and vomiting with the medications. The big deal with this is you need to have 95% at least 95% medication adherence. If you fall out of that, if you're not being as diligent with your medications, those meds can become useless for you. The virus will just start working, and those meds are not affecting it anymore. And unfortunately, I've definitely seen this in a couple cases where the patient just was not adherent to the regimen, and then they had to they had to change their regimen. They get them on one that's working, and then they just they're not compliant with that. And I've seen it where they've gotten down where I've heard the doc say, look, this is probably the last regimen that's going to work for you. You have to stick with this. We're going to run out of things here, and then unfortunately the virus is going to take over, which is very scary. So we really have to preach medication adherence, and we need to do everything we can to assist them in maintaining that. So patient teaching, again, is all about promoting adherence. They need to understand the medication's purpose, management of those anticipated adverse effects, and how we can support them. We can support them in different ways. Everyone's going to have, some people are going to be very receptive, and they're going to be on it. They're going to program their phone to alarm them, and they're going to have their meds with them at all times, and they're going to take it as soon as that alarm goes off, and they're going to be very precise with their adherence. Others are not going to be as productive, I will say, and for various reasons. It's not because they don't want to be. It's there's different hurdles involved with different people. So you can use pill organizers. That helps people setting alarms. Like I said, we all carry a supercomputer in our pocket nowadays. We at the very least can set 15 different alarms if we need to. So with just a pill organizer and alarms, I've seen people that's enough for them. That's enough adherence, that's enough for them to promote adherence and be on top of things. If we can get them to start getting it involved in their daily routine, they wake up in the morning, take their pill, go about their day, and then they take their pill again at night when whatever it is they do after they shower or whatever it is. If we can get them to put that in part of their routine, that helps, because we're all creatures of habit. If we can get that habit built, that's good. Some people use diaries and calendars, and that helps them. Healthcare contact person, that's very, very important for them to understand. They always have someone to reach out to for any questions or concerns. That does help. And then personal support system. Now you got to be careful. Of course, you can't just immediately go out and say, well, I know John goes to the Church of Christ down here. I'm going to go talk to the pastor and see if we can get some people to help him come over and remind him to take his HIV medicine. You can't just do that, obviously. You're breaking a lot of HIPAA rules there. So, but you can ask the patient, who can we reach out to? Who is available that you feel comfortable with helping you? I have absolutely done this before. So I've worked with HIV patients in the past. on multiple levels. And one patient I can think of in particular who just had trouble remembering to take his meds. He had a lot of comorbidities, and the meds unfortunately caused him some adverse reactions that he wasn't too fond of. So that was a hurdle as well. What we ended up doing is sending a home health aide out there every single day, and she couldn't give him the meds, but she could hand him the box and watch him take the med and then call if he didn't, and then we could get in, we could call and come out and see him and try to see if we can help him with whatever's bothering him that day. We've also so that was his daily. He needed to take it twice a day. And then we eventually got him to agree to allow his daughter into his care. Reached out to his daughter, and his daughter was diligent about every single night stopping by or calling him and reminding him to take his medicines and sitting with him till he did take his medicines. And we got his compliance up. I mean, it was terrible at first. It was very common for me to go. I'd go every week and look at him, and it was common for me to fill his pill organizer each week, and he would miss 3 or 4 doses, which is not going to be conducive to him getting the treatment he needed. By instituting these interventions, we were able to greatly increase it. Every once in a while he would miss a pill, but it was very rare, which is good, and it definitely helped him. It promoted his health, and he started feeling better. Everything was better. So you're going to do what you got to do. Of course, obviously, though, respecting the patient's wishes and the patient's right to privacy. You just can't go to the neighbor, knock on the door, and say, "Hey, I need you to come over here and remind him to take his HIV medicine." That's not appropriate. But maybe he feels comfortable with the neighbor, or maybe he feels comfortable with whoever. We can institute some interventions to help, pull those people in to help institute those interventions. Occupational health exposure. So as a health worker, you are also at risk, kind of, right? I mean, we are going to use our standard precautions, but standard precautions are only good against so much. Gloves aren't going to stop a needle. So if you get stuck with a needle, stuck with a sharp, which could include a scalpel or any other sharp, and there's been body fluid exposure there, you're at risk. The good news is we have post-exposure prophylaxis, which is a medicine you take. It's an antiretroviral medicine you take in order to not allow the virus to take in your body. The thing with this is you've got to start as soon as possible, within 3 days, but realistically they want you to start within 24 hours. So if at any time you get stuck or exposed, if blood maybe got into your eyes, or maybe you had a cut on your hand and the glove ripped and you got blood on that, you need to follow your organization's policy for post-exposure, and potentially maybe even need this medication. The policy is normally, of course, as soon as you get stuck, wash your hands with soap and water. Don't use the alcohol scrub. It does nothing for you. It's all about the soap and water with the water running over it, and then of course the friction from just the rubbing. Do that for about 2 minutes, and then contact your point of contact, whether it's your charge nurse, whoever it is, whoever's in charge of whoever's the next step. Usually then they send you to OC Health or the ER. You'll have to have your blood drawn. Then we'll have to get consent from the patient to allow them to have their blood drawn. They do not have to consent, at which point we need to now do a risk analysis. We need to look and say, you'll contact the doctor, let them know what happened, and the doctor can look into this person's history and say if there's a risk or not, whether you should be concerned about taking the post-exposure prophylaxis, or whether you're very, very minimal risk. You usually use these for about 4 weeks. And like I said, they certainly come with side effects. It's very, very common for you to get fatigued and nausea, just not feel very good for 4 weeks, but it's much better than having to take those medicines for the rest of your life in order to keep the virus at bay because you became infected. So always keep that in mind. Anytime you get a stick, immediately wash your hands, obviously, fess up to it, and go get your help. Don't feel embarrassed by it. We've all done it. I did it once on a insulin needle, and thankfully it was a little old lady, but you never know, man. Those little old ladies can get around. So I went and got my blood drawn. She agreed to have her blood drawn. Of course, the risk was very minute, so it's not like I decided I need to start those medicines right away. I knew I could wait a little bit for those results. The results came back. Everybody was fine. Great. We're good to go. But I've seen people that have unfortunately been stuck in high-risk situations, and they're thankful for the post-exposure prophylaxis, because this stuff is pretty, I want to say it was like 85% effective or something like that. Unfortunately, I don't have that research in front of me. I know I've read it. It was really effective. Don't quote me on the exact percentage, but it was really effective. If I was ever in that situation, I'm not thinking twice. If the patient is a high-risk patient, I'm taking it. I'm not even thinking about it. All right, anti-neoplastic agents. Just like with our HIV agents, I'm not getting into specific meds. There's a bunch of specific meds, and you're not necessarily going to deal with those meds that often. If you deal with cancer meds or anti-neoplastic meds, you're going to have special certifications anyways. So I'm not going to get into specific cancer or HIV meds. I'm just getting into the basics of the meds, or as far as nursing considerations. That's really what I'm most concerned about, you guys understanding the basics of the pathophysiology and the basics of the nursing considerations. So let's look at the pathophysiology just a little bit. So obviously cancer starts with a single cell, and it's just different than the other cells, right? It's just different. That cell loses its differentiation and organization and just no longer functions normally, and that's called anaplasia. So the cell no longer functions normally. The cell starts to grow without its normal restrictions, right? So if we think about it, our eyes are only so big, right? So the cells that make up our eyes can only grow so big and only do their one function. Same with our lungs and heart, right? These cells are constantly being replaced with cells that grow to the same size and do the same stuff for the most part, right? Whereas cancer, you get one in there that just acts differently. It decides to grow well beyond its normal natural restrictions. So it grows without those restrictions. That's called autonomy. So this allows the cells to form a tumor. Angiogenesis occurs when those cells the cells grow into a tumor that they need more energy to feed themselves than what they're being supplied. So now they just generate their own blood vessels. So they're feeding themselves through these blood vessels. Thereby robbing the rest of the body, or in the healthy cells, of the nutrients it needs. And then metastasis is when those cells travel to different areas of the body and develop new tumors in the body. Possible causes of cancer, and again, it's possible causes. They have correlations. Smoking is correlated with certain types of cancer, but we've all known, Grandpa, Cletus, who lived to be 104 years old, and he smoked non-filtered Camels every day of his life. So it's not like just because you smoke you're going to get cancer. We just know that it's a higher risk. So the biggest thing, of course, is probably genetics, really. We definitely see a very large correlation between people with his family history of cancer and their risks. So genetics is probably the big one. Then certain viruses put us at higher risk. Think HPV, right? HPV we know puts females at higher risk of cervical cancer and puts everybody at higher risk of throat cancer. Stress, we've seen stress has been correlated or has a high correlation with the risk of cancer. Constant irritation and cell turnover by whether it's mechanical or usually it's medications or certain pathophysiology within the body. Lifestyle factors, smoking, drinking, those types of things. And then environmental factors. We've all seen Aaron Brockovich, so I'm sure that we can understand that one. Goals for treatment: destroy the cancer cells. We can do that through surgery, radiation, drug therapy. Sometimes just decrease the size of the neoplasm, whether it's through radiation or drugs. And then sometimes it's just palliative. Just we know that the person's not going to their prognosis isn't well, but we can make them feel better by maybe getting rid of some of by taking surgery or using surgery to take out some of the cancer tumors. So sometimes it's just a palliative thing. Mechanism of anti-neoplastic drugs: they interfere with cell survival, boost the immune system. Usually it's a combination of drugs and therapies, right? It's usually not just surgery, not just radiation, not just one anti-neoplastic agent. It's usually multiple agents plus radiation or multiple agents plus surgery or all of it. It's usually a combination therapy, and it's pretty specific to the patient. Obviously there's lots of research on what works best for different types of cancers, and we're getting more and more specific, which is awesome. We're getting much better at treating cancers, but we certainly aren't perfect at it, and it's individualized. As far as the cell-specific cycle, I'm not going nuts about this. I'm just giving you some information here that you can look through. Cancer and chemotherapy, always look at your treatment protocols. In all honesty, if you're giving chemotherapy, I've never worked anywhere where any regular nurse can give it. You always have to have certifications, even to give the pills. A lot of times I've seen, the person takes this one pill every day. They still send up a chemotherapy nurse every day to give that person the pill. If for whatever reason you did have to give one of those pills, just understand that there comes with certain risks. Make sure you're wearing gloves, and you understand that a lot of that med is going to be eliminated through feces and urine, and a lot of times with most of those meds we have to be very careful with the way we dispose of that stuff as well. There's lots of side effects, of course, with cancer chemotherapy, because think about it, it's going after those fast-growing cells, which, mucous membranes, hair, and this correlates with a lot of the side effects. Let's talk about some of those side effects. Anemia. What are we going to do to assess for anemia? Think about the ways that we assess for anemia. Anemia itself just means decreased red blood cells, right? So if we decrease red blood cells, it means we're decreased hemoglobin, decreased oxygen carrying capacity. So we're looking at shortness of breath, fatigue. They may have some tachycardia as the body tries to make up for that lack of oxygenation. Maybe some hypotension. They certainly will be breathing maybe a little bit faster, a little bit heavier. And cyanosis is another. Nursing interventions, we can assist them with activity, planned rest periods through the day, raise the head of the bed, right? Anytime somebody's shortness of breath, it's good to raise the head of the bed. Neutropenia, what we're assessing for here is just signs of infection, right? Neutropenia is low white blood count, so we're going to assess for signs of infection. And then As far as nursing interventions, we can take neutropenic precautions, washing hands, limiting visitors, teaching visitors about the importance of wearing, like usually you have to wear the isolation gown, the mask, the whole bit. Certainly don't let anyone visit that is ill at all, usually no children. And then avoid infections. So again, no children, avoid being around people that have infections. And I mean, it's not like you can eliminate this all the time, but you're gonna do the best you can. No fresh flowers, no fresh fruit. Thrombocytopenia, decreased platelets. So we're assessing here bleeding, right? We're assessing for, lots of bruising, bleeding. We'll look at their stool, urine, make sure that there's no symptoms of bleeding there. Apply pressure to sites. So these are our interventions. So if you have to do a needle stick, make sure you apply extra pressure, for a longer time. Avoid invasive procedures if possible. Anorexia. Again, people that are on chemotherapy, a lot of times they have nausea and vomiting. They have mucositis, which is those patchy, painful white patches in their mouth. All these things lead to them not wanting to eat. So anorexia is definitely a problem that you'll see with people. So if we could provide small, frequent meals, do good mouth and oral care, the meals that we do provide, let's try to make them as high calorie and high protein as we can to promote healing and promote intake, as so make the most of it. If they're ready to eat, let's get them to eat some high calorie, high protein stuff. Nausea, vomiting, again, let's minimize odors and stimulation, frequent mouth care again. Diarrhea unfortunately occurs a lot of times, so let's, again, small frequent meals. Maybe try to monitor for triggers, and we can try to limit those. Assist with toileting. Mucositis, like I said, that's those painful white patches in the mouth. We can offer ice, popsicles, good oral care. There are medications available that help with that as well. Alopecia, depending on the person, they may have some body image, problems with that. Encourage wigs, scarves, hats. With fatigue, we can plan our activities to conserve energy. So, try to group things together, but not so much to where we're going to wear them out, and then give them breaks, give them rest times. Encourage a well-balanced diet. We actually want to encourage exercise in times when, and certainly before the fatigue gets before it really starts to get bad. If we can encourage exercise early on, that will help hold that fatigue at bay and it won't be as bad later on. As far as infertility is concerned, especially with our female clients, a lot of these medications and therapies can render a person unable to have children afterwards. So we need to start that talk immediately. If they're of childbearing age, we need to discuss, hey, have you had children? Do you want to have children in the future? There are things that we can do, right? We can freeze eggs. There's things we can do to help them, but we need to institute that immediately before we ever start the treatments. So patient teaching. We're going to teach them about the treatment plan, make sure that they comprehend the treatment plan. They're going to have, their whole world's been thrown into a tailspin, right? They've been given this diagnosis. Once you hear cancer, you just immediately start thinking about a limited life, and anything else anyone tells you is just white noise. So really trying to comfort them through this and make sure that they understand the treatment plan going forward, and just as important, that they understand there's somebody there available at all times. So give them a number that they can call, that somebody will be available. Somebody's always on call to take your call concerning any questions and concerns that the person will have, and they will have many. And believe me, those don't come at 1 p.m. They come at 1 a.m. So they need to know that they have somebody. So let's make sure that they have that in place. They need to understand when their follow-up appointments are, who they're following up with, and where they need to be. They need to understand what to report to healthcare providers, common adverse effects, and how we're going to help them deal with those as well. Immune modulators. Interferons, these prevent viruses from replicating. They inhibit tumor growth. And there's a brand of interferon called Avenox, or interferon beta 1A, which helps treat multiple sclerosis. So they have multiple things that they do. Interferons are normally given sub-Q or IM. And again, they're used for cancers and viral infections primarily, but we've also got one that we use for multiple sclerosis. Interleukins, they inhibit tumor growth. So, of course, they're used for cancers, and we usually give those IV. I believe those are only IV, actually. Then colony-stimulating factors. These increase production of white blood cells. So we use them for neutropenia, bone marrow transplant, chemotherapy. And these are normally IV or sub-Q. Adverse effects of these: flu-like symptoms, GI distress, and bone pain. We're going to teach people that they will cause those flu-like symptoms, so be prepared for that. They'll need lab work to check and see how these are affecting them, and then they will also want to avoid pregnancy. Immune suppressants, these decrease immune activity and inflammatory response. We use them for organ transplant, autoimmune diseases. There's an increased risk of infection in neoplasm. There's that figure that we were talking about back there. Patient teaching. Avoid people with active infections. No live vaccinations. They'll need periodic lab tests. Avoid pregnancy, so they'll need to use barrier protection. And notify provider of signs and symptoms of infection. Vaccines and SARA. Types of immunity. Active natural immunity, that's when the body produces antibodies in response to an exposure to a live pathogen. So this just means you got sick, you got better, your body built an immunity to it. So you got, cold number 184279 or 12XYZ. You got better, so now you have antibodies against, I don't remember what I just said, but the one I just said. Unfortunately, the colds, viruses, rhinoviruses, they mutate so often that we'll end up getting it again anyways, but at least we'll have some immunity to it. Active artificial immunity, this is a vaccine, right? So the body produces antibodies in response to an exposure to a killed or weakened virus. So that's your active artificial, that's your vaccine. Passive artificial, this is where you're injected with preformed antibodies. So the antibodies were formed outside. They were injected into us after exposure. So think of antivenoms, antitoxins. Passive natural immunity, I don't have that on here, but it always seems to come up in class. Passive natural immunity, that's again preformed antibodies that pass on naturally, which would be breastfeeding or mother to child in the third trimester. Immunization. It's an artificial stimulation of immunity, exposure to a weakened or killed pathogen. The goal, of course, is to cause an immune response. That's the goal. We want to cause that immune response, but we don't want to have to suffer the full course of the disease in order to build the antibodies, right? So people commonly after a vaccine will feel, some slight symptoms for like 24 hours. I know myself, after the flu vaccine, I always feel a little blah. I've had the live flu vaccine once in my life. I'll never do that again because I just felt horrible for about 12 hours. And luckily, they gave it to me at the beginning of my shift. So I was very lucky in that. I came in. They were worried about the swine flu, so they went around the hospital and just made everybody sniff this vial of vaccination. And they said, "Here, you got to take this." So I snorted it up. I went ahead and lined it up though, so I could snort it appropriately. And the rest of the day I was just useless. I was the worst day of work I've ever had. So I would not recommend the live one ever again. In fact, I don't even know they make that one. But again, the goal is to have an immune response, but not suffer that full course of the disease. Vaccines, again, immunizations that stimulate formation of antibodies. They provide that long-lasting protection. The good news is their use has eradicated some disease. Look, I get it. There's, for some insane reason, there's a controversy out there. And, we as nurses are bound to an oath to do no harm and to promote health. All the research on vaccines, all of it out there, states that they are beneficial. There's no research out there that shows that the overall harm of vaccines. That's not to say there are not individuals out there that will respond badly to vaccines, and it's not to say that if your child had responded to vaccines that you would want to just continue giving them. I get that. But overall, for the most part, vaccines have been proven to be extremely safe, and not only extremely safe, but if we look at the mortality rates from before vaccines to post-vaccines, it's pretty obvious the vaccines have had a major impact on our quality and length of life. Now, certain vaccines would be recommended due to certain exposure, right? Some people are more at risk for exposures than others. When you go into the military, you get just vaccinated against everything. They just vaccinate you, and you just line up in a line, and they just come by and just shoot you with all kinds of stuff, right? But you have the potential to be exposed to all kinds of things. Whereas, just basically living here in Middle America, there's, you still have to have certain vaccines, but it's not nearly as many. We don't worry so much about tuberculosis or smallpox, not yet, anyways. So it all depends on your possible exposure. Adverse effects, again, it's, you're going to have an immune response. So you're going to have some symptoms, some slight symptoms, like a low-grade fever. It's kind of common. The most common is pain and redness at the injection site. We've all had a Tdap in our lives. You've had to have had a Tdap in order to get into this program, and we all know the Tdap sucks. It hurts. Makes your arm hurt for like 24 to 48 hours. For some reason, you start limping too. I don't understand that, but you get it in the arm, but for some reason, you're like holding your ear and you're limping out, right? I don't know why. It hurts. Rash is common, malaise, joint pain, irritability. Some people even may have experienced some vomiting. The good news is it's usually short-lived. If it comes on, it's pretty significant, or lasts longer than 24 hours, then we definitely need to follow up. Some common childhood vaccinations. Again, I'm not expecting you to know know when these are all given. You will get that when you get to peds, but just know that these are the common childhood vaccinations. We're going to start there. Adult vaccinations, we will talk about a few of these, and you probably know them already. The influenza we usually give seasonally, so it's every year. The Tdap's about every 10 years, although you will see people sometimes get a booster if they haven't had one over 5 years, depending on the exposure. So if they step on that proverbial rusty nail everybody talks about with Tdap. If you step on that nail and it's been 5 years since you've had a Tdap, they'll probably go ahead and give you a booster just to make sure everything's okay. But it's primarily every 10 years. Varicella, the human HPV. So HPV now we've started, it started off being recommended for females. Now it's boys and girls ages 11 plus. The zoster we recommend for people over 60. Pneumococcal we recommend for people over 65, so everyone over 65. However, we do recommend it for anyone that's at risk for pneumonia or they're immunocompromised, and sometimes it's even recommended for smokers that are less than 65. And hepatitis B, we're healthcare workers, so it is recommended for us. Sometimes we're going to go to a place where maybe we might be exposed to potential viruses that we're not necessarily exposed to here, or potential microorganisms anyways. So you may need immunization before foreign travel. We talked about with the military, you get quite a few. So again, depends on the destination. On the destination, you can go to the CDC website to get further information on that.